The Jessie Stewart Richardson Memorial Lecture was created at UVA in the School of Medicine in 1999. Coincidentally, the same year, the Institute of Medicine published its landmark report on errors in healthcare. To err is human. Since then, this lectureship has sparked a sustained conversation at our institution on the sensitive subject of medical error. The lectureship remembers Mrs. Richardson, a former school teacher, whose untimely death occurred as a result of tragic adverse events in her care at this hospital. Her long career in education prompted her family to invest some funds in medical education so that health professionals at UVA might know better how to commit themselves to care that has the patient at its heart, and to explain and to explore without fear medical mistakes when such events occur. As every year, we'd like to welcome Mrs. Richardson's son, Dr. Don Richardson, and acknowledge both his loss and his family's gift. We're grateful for his continuing collaboration and his generosity of spirit in cooperating with his medical school. Welcome, Don. It's been a real privilege to work with you over the years on this. Pleasure. The annual Richardson Lectures have given students, clinicians, educators, and administrators opportunities to learn better how to prevent medical mistakes, address them when they happen, improve patient safety within complex medical care, and assure patients and families of the best possible outcomes. An evolving conversation on an urgent subject now addressed across the world. Our lecture series has brought to UVA noted experts from across the nation. But several times we've also called on persons here at home, including clinicians and patients' families, to give us counsel. So our Richardson lecturer for 2014 is indeed one of our own, although quite recently arrived, and with established expertise in patient safety. Dr. Richard P. Shannon, since last November, the Executive Vice President for Health Affairs for the university. You'll find in your handout a brief description of Dr. Shannon's illustrious career to date in both medicine and healthcare academic medical leadership. We're proud to welcome him as our Richardson lecturer, and so pleased to note that this lecture is a signal opportunity for him to engage all of us here in an important conversation about patient safety and quality, what he sees as the new currency of academic medicine and central to the mission of academic medical centers, especially our own. Once again, this year, the Richardson Lecture is a cooperative effort of the Medical Center Hour and the Medical Center's Patient Safety Committee. And please join me in welcoming Dr. Richard Shannon.
Thank you, Dr. Childress, and thank you all for joining us. Thank you, Dr. Richardson. I am privileged and honored to be the 2014 Richardson Lecture. And I'm particularly privileged and honored to be with you and to spend some time with you in discussing something that I think is of interest to all of us and a particular passion of mine, and that is UVA, our journey toward the pursuit of excellence and quality and safety for our patients. And I begin by telling you I am part of you. I feel much more comfortable in that audience than I do in much of my new role. I want to let you know that I'm going to hopefully exhort you today to continue on the journey that you've long been on, and also challenge you, I think, to pick up the pace as we together aspire to be the safest place to receive care. Now, I want to begin the discussion with a value proposition, because at the end of the day, despite the focus on process and outcome, it is an organization's values that determine how far you will go, or we will go, on our journey toward excellence and quality and safety. And this is borrowed from the American Board of Internal Medicine's Charter on Professionalism. And it actually recounts, for the purposes of professionals, all healthcare professionals, their duty to society, the special contract that we have with society that gives us the privilege and the honor to take care of patients. And I highlight for you two things that the Charter on Professionalism calls all health professionals to commit to. And that's the improving quality of care, and to be just stewards of finite resources. The idea that quality and safety is a fundamental tenet of our commitment to our patients. And at the same time, we have to see how that might link to being better and more finite stewards, and to be better stewards of finite resources. Now, the discussion of quality and safety takes on a sense of urgency when one considers the crossroads that the U.S. healthcare system finds itself. I think you all know that the projections of the Congressional Budget Office say that by 2023, the current Medicare trust fund will be completely out of money. No opportunity to pay the bills of U.S. elder citizens in the year 2023. And that's largely a consequence of the growing rate of healthcare expenditures that have occurred over the better part of the last 2 or 3 decades. And as said best by the Stanford health economist Victor Fuchs, if we solve our nation's healthcare spending, practically all of the nation's fiscal problems go away. And if we don't, then almost anything else we do will not solve the nation's fiscal problems. So the nation is very much dependent upon the provider community to take up the cause of figuring out how to generate value in a system that finds it easy to spend $2.7 trillion a year, the current expenditure on U.S. healthcare. Now, the consequences of this are more than a large number. You know, people say $2.7 trillion. If you say it fast enough, it doesn't sound like a lot of money. You know, billion, million, trillion. But one of the students in the Leonard Davis Institute when I was at Penn illustrated how much $2.7 trillion really is by the following example. He said, this was Peter Gronevelt, if I had a $1,000 bill, which I certainly do not, but I have a $1,000 bill, and I were to lay it on this lectern every 5 seconds, it would take 428 years to count out $2.7 trillion. Yet we spend it annually in the U.S. healthcare system. And the consequences are not just that expenditure. They're the fact that over the last decade, for every dollar increase in healthcare premiums, there has been about an 81 to 83 cent suppression of workers' wages. The erosion of the U.S. middle class is not about education and jobs. It's about the fact that employers have had to pay escalating healthcare premiums and not give wage increases to workers. It's a simple trade-off. And so the consequence of this really is considerable across a whole social strata of the American population. And in addition, the nation is forced increasingly to make untenable social choices. So you can pick your social cause up here, but the U.S. spends 8 times more on healthcare than it does on education and 87 times more than it does on clean water. Things that a civilized society would argue are pretty unassailable values. And education is my favorite because I had the very uncomfortable experience of being invited once to City Hall in Philadelphia to meet the mayor of the city of Philadelphia, Michael Nutter. He convened 6 or 7 healthcare leaders from around the city of Philadelphia, and we all thought we were being invited to a nice conversation with the mayor. We were called into the anteroom and told by his spokesperson that the mayor was very upset and that he would speak with us shortly. We all paraded into the mayor's office, and he looked at us and said, tomorrow I'm going to announce the fact that I'm closing 22 schools across the city of Philadelphia. And it's because I cannot afford to pay teachers and to pay the 17% increase in healthcare premiums for the workers of the city of Philadelphia. He said, this is on you. Very telling moment, not exactly what I expected to be my first introduction to City Hall, but an illustration of the fact that what we are doing has consequences far beyond those of our individual interactions with our patients. Now, there are really two courses the nation can take in dealing with this. One is the payer approach, which is the cutting philosophy, right? Cut reimbursement for services, cut services themselves. The nation has long been on this trajectory of trying to impose price controls on Medicare as a way to control the expenditure, none of which has worked particularly effectively. Yet, over time, price controls will have the untenable consequence of limiting access of elders and the poor to services, if in fact those cuts continue. And it's almost been death by 1,000 cuts, right? Every year something new, some new nuance. That's an approach to solving the nation's healthcare problem that deals specifically with cutting and the payer side. But the provider community has another opportunity, and that's to improve our way out of this by recognizing in our daily work that there's a lot of things we do that don't add value to the patient's experience. Much of what we do, quite honestly, doesn't focus on patients' needs. We need to really focus on how we can decrease those things that add no value. This idea of the right care for the right patient in the right place. And in fact, many actuarial estimates suggest that if we eliminated the waste, the things that add no value to the patient experience, it would result in somewhere between a $6 to $9 billion, $6 to $900 billion savings a year, and about a $6 to $9 trillion savings over a 10-year period. A sizable opportunity for doing the right thing. So why have we struggled to do this? Why is academic medicine the nation's leading light in so many fields of health and medical care? Why have we lagged in taking a leadership position on this? Well, I think first and foremost, I don't have to tell you, you live this, we are infatuated with reportable but inactionable data, right? Stuff that piles across our desk or our computer screen on a daily basis, which we glance at, maybe study, but take no specific action on a daily basis to affect it. We watch the data. Secondly, we are now awash in a sea of meaningless measures. 1,700 measures certified by the National Quality Forum. 1,700 measures. And what this leads to is the outcome that we see today, where there are 1,000 US hospitals that claim they're in the top 100. Because every hospital can find something in 1,700 that they're really good at. Third, we lack a disciplined problem-solving approach to the problems and the data that we have. Said differently, there's no reason to look at data unless you're going to do something with it. To measure it and not intercede on it probably isn't a useful purpose. Fourth, in our busy days, despite being in an academic medical center, we leave our workforce little, if any, time to learn how to work better. And then finally, all this effort consuming our organization leads to really slow progress. And as a result, we often confuse effort with success. Now, I think the problem specifically in quality is we've actually gotten pretty good at quality as a project. We can make things happen for one condition, for one unit, for a while. And we've all had the experience of that. But we haven't learned how to get measured results quickly across many different conditions, across a whole organization. Organizational excellence as opposed to unit excellence. And that's because quality is never an accident. It's always the result of highly intentioned, highly directed, and skillful execution. It requires a disciplined problem-solving approach that's embraced daily, and never in the conference room, but always at the point of care. Now, I'd like to graphically illustrate with one of several naval analogies I'm going to share with you today what I mean by the difference between a project and a system-level goal. So this is a project. This is a naval exercise off the coast of San Diego, probably La Jolla, that beautiful beach, where there are a series of naval cargo ships practicing landing on the sunny shores of La Jolla. A project designed to test how well they can put supplies on the shores of La Jolla. This is a system-level goal. This is the Normandy landing, where good people from many nations came together and were willing to sacrifice everything for one cause: the defeat of the tyranny that reigned throughout Europe and Asia. We do a lot of this. We need to do this. We need to declare, as an organization, enough. No longer will we tolerate inadvertent harm to patients in any form. And that our daily task is to work toward that pursuit. Now here's kind of where I think we often find ourselves. Right? This is this wonderful cartoon, a bunch of happy people sipping their martinis in the bow of the boat, saying, boy, I'm sure glad the hole isn't in our hand. And everybody in the audience can relate to being in either of the two positions at any one time, right? We've all been in both. But I, for the purposes of this discussion, would say that too often in our organization, I find myself at the bow, and then the people that are actually trying to, create leapfrog A are bailing away, and the people that are trying to create magnet are bailing away. But there's a bunch of us sitting in the bow saying, boy, I hope they are successful. Won't work. The work of achieving excellence is the work of everyone. Excellence cannot be pursued, let alone achieved, unless the wisdom and the skill of everyone is engaged. Not just the leaders, although that is absolutely necessary, but everyone. Everybody in the organization. Everybody here and the hundreds of people that follow you. Now, how does one if one accepts the argument that there is this narrow window of opportunity where we can improve our way out of the healthcare dilemma, how does one approach that? So this is Don Berwick's wonderful concept of the wedges of improvement. The idea that here is the current expenditure on healthcare in 2012, and that there are valueless, wasteful activities that will contribute to the escalation of the U.S. expenditure on healthcare over the next decade. And that if we committed to eliminating these things, which we would all acknowledge add no value, we could actually bend the cost curve without cutting reimbursement, without cutting service, without limiting access. But this is a serious pursuit because these are exponential rates with which these numbers are increasing. So Berwick identifies the wedges of waste as harm, and I'll talk principally about that, but overtreatment, defects in care delivery, defects in care transition, excessive administrative costs, and fraud and abuse. And you can see that fraud and abuse is a very small part of the story. So it's important, but the idea that we can fix healthcare by audits, probably not likely. Can we fix healthcare by doing away with things that we, as a provider community, recognize add no value, and we, as patients, are intolerant of? Right? How about when we're on the other side? What kind of high standards do we expect? Why don't we then, on a daily basis, act that way, as best we can, within improving systems? So, why would I submit to you that we as an organization ought to begin by becoming the safest place, which obviously is the absence of all harm? And harm, parenthetically, it can be defined very broadly as anything that you would like not to happen to you or a loved one when they come to the hospital, right? You could define it really, really broadly. But I'm going to define it relatively specifically today. And I'm going to suggest that the reason to begin with safety is it is unassailable. No one can argue with it, right? By evidence of the following. Please raise your hand if you'd like to get an infection when you come to the hospital. Nobody ever raises their hand. No one argues with it. Even the most strident physicians don't try to debate the matter. So safety seems like a safe place to start, because it doesn't, deal with rationing and what we should do about advanced care for 80 years old people and who should get cabbage surgery. Tough stuff. It really deals with an unassailable issue. Secondly, it violates our professional duty, as I mentioned on my first slide, and as embodied in the Hippocratic Oath. It is the most elementary form of waste. It is completely valueless, and we know it can be totally eliminated. What better place to start? Because I think an organization that can become completely and totally safe builds institutional confidence that you can do anything. You can do anything. Now, it's a big problem, and it's a big part of the wedges of improvement. So 5 to 10% of all inpatient care is compromised by a hospital-acquired infection. There's still about 1.7 million of these, more than a decade after the Institute of Medicine report. Still 100,000 people dying of untoward events in US hospitals on a regular basis. And it's somewhere around a $30 billion proposition, right? A $30 billion waste that nobody wants. And my question to you is, how safe are we? On the left is an Alcoa aluminum plant where they make hot molten metal on big cranes that run along football field-sized factory floors at 10 miles an hour in the hands of largely high school educated individuals. And on the right is a US hospital where most of us in the room who are professionals have been educated for about 20 to 25 years. So the answer is simple. It's actually 27 times safer to work at Alcoa than it is to work or walk into a US hospital. 27 times safer. What's that all about? Well, part of it is about a leader, Paul O'Neill, who said, we will become a Fortune 100 company if and only if we agree no one gets hurt at Alcoa. Interesting. He didn't say if we make aluminum stronger or better or cheaper. His belief was that if Alcoa was the safest place to work, they would make the best product and they would have the best outcomes. A very interesting example about doing well by doing good. Not focusing on the product, focusing on the people. And it was from Mr. O'Neill, who parenthetically will be with us next month as part of one of the U-Team engagements, that I learned much of what I'll share with you today. So the real crux for us as learned people in this really storied institution is the following two challenges. Can the elimination of harm in the form of hospital-acquired infections, medication errors, readmissions as examples, serve as a starting point for reducing unnecessary waste in the healthcare system? And in doing so, can we duly fulfill our professional obligation to both do no harm and be good stewards of finite resources? Can we fulfill that contract with our patients? So I'm going to share with you briefly 5 lessons of high performance that I think are opportunities for us to improve upon the really terrific work that is ongoing. But we can't be satisfied with where we are. We must accept the challenge that no harm is acceptable. That we live in an environment that is considerably safer than it was. But it is not safest. And we shouldn't rest. So here are 5 approaches that I think can take the really good ongoing work in our organization and accelerate it. So I'm going to begin with the importance of actionable data. Now, I want a caveat. If I say something here that somehow rubs you the wrong way or appears for me to be critical of something that's gone on or going on, remember, I'm part of you. So I'm being self-critical. And as I am critical of myself, so too I try to exhort myself to do better. But if you don't appreciate where you are, really hard to get better. So take no umbrage. Take action. Be challenged by the things I'm going to present to you, which may or may not exist today, but are, I think, fundamental to really excellent performance in safety and quality. So first, the importance of actionable data. There'll be 5, but let me start here. So this is the way, in 2002, I presented central line-associated bloodstream infection data to the Department of Medicine where I was the chair. And I did this dutifully because this was what I thought was actually engaging in quality. If I simply showed everybody that I was looking at this, they would think it mattered to me, and they would likely engage. So here's what I show. Now, behind this, so this is, infections per 1,000 line days per quarter in a 26-bed ICU. This is just 26 ICU beds, not across the organization. God forbid I show that data. Right? 26 ICUs. And there were a legion of people working in the basement of the Department of Medicine, spending time putting this data together by trying to figure out line days. Counting in the medical record how many days the damn catheter was in. Hours upon hours of time going through this, debating in, out. And it was just so I could show these data. And somehow, the theory was, if the data were statistically intricate, that would confer authenticity. Right? So I would say, here it is. This is our data for the last 2 years. And everyone would look there and go, well, that's very interesting. These must be Dr. Shannon's patients and my patients. Totally the other way. Right? Or these are the surgeons and these are the men. And then, of course, someone would say, oh my God, look at the variation here. How can it be that we're good here and then bad again? What's that all about? So we try another statistical trick to take people's eye away from the variation. And we average the data. We say, don't be concerned about the variation. Of course, where you see variation, it tells you there is no system. Variation equals the lack of systemness. So we say, no, we don't want to, let's not confuse anybody. Let's just tell them there are 5.1 infections per 1,000 line days. It sounds very authentic. And people say, I get it now. 5.1 infections per 1,000 line days. But is that 5 people? Is it 50 people? 500 people? What were we really sharing? And then, of course, board members would ask, so how do we compare? And so we did the second statistical trick, which is we benchmark. And whenever you benchmark, it's a funny thing, you always find something against which you benchmark better, right? That's always your benchmark. So we, at this time, benchmarked ourselves against the National Nosocomial Infection Surveillance data, the CDC. We tell better than the NNAIS. Oh, my God. And then someone would say, okay, but how do we compare to our neighbors, other organizations near us with whom we compete? And of course, in this case, when we were in Pittsburgh, there was a regional collaborative, 43 hospitals that come together to basically report their data. And so we weren't quite as good as the Pittsburgh Regional Healthcare Initiative 43 Hospital Consortium. But at the end of the day, we were just where we expected to be, average. Off the front page of the newspaper and perfectly average. Now, this infatuation with statistical analysis, punctuated by the idea of creating comparative benchmarking, is what Paul O'Neill came to call defining the cream of the crap. Right? Because again, please raise your hand if you'd like to get an infection. Please raise your hand if you think somebody else ought to get one. And isn't the only number 0? And if as an organization you declare that 0 is the goal, you don't need all this stuff. Suddenly the people that are in the basement going through the records trying to figure out the denominator are free to go do work that actually might eliminate the infections. Now, I recognize someone out there requires the data to be normalized. I accept that. But we shouldn't be preoccupied with that because it really doesn't create actionable data. Now, what turned out 5.1 infections per 1,000 really meant in this 26-bed ICU was 37 people got a total of 49 bloodstream infections. That's actually, you could get more than one. That we were infatuated with access. The average patient in the ICU had 5.2 points of access. And when you ask people, why do you need 5 points of access? Actually, patients are very sick. I said, but we're only using 2. So we need the other 3 in case the other 2 don't work. Well, why wouldn't they work, right? The whole argument was circular. 1,753 admissions, 2/3 of patients got some form of central access. 1 out of every 22 patients in this 26-bed ICU got a bloodstream infection when they had a central line. 1 out of every 22 patients with the central line got a bloodstream infection. 6 sigma. This is 1 times 10 to the first. We were actually reporting half the infections. This was a good one, right? We said, oh, femoral catheters. They don't really make it to the central circulation, so we shouldn't count this. You laugh, but I'm sure we've watched games be played, right? No, let's not count those. Central. 2/3 of them with virulent organism. This is not a staph epi issue. And then here was the punchline. 19 of the 37 people died. So you can tell your group it's 5.1 infections per 1,000 line days. You can tell them we had 37 people, 19 of whom died. Different message. Different message. And I'd have some smart internists in the back of the room raise their hand and say, Dr. Shannon, you're not trying to tell me that these very sick ICU patients died because of the bloodstream infection. I said, you know, I really can't tell you that, but I guarantee you they didn't get better. Right? It is not the defined way to vasodilate someone to give them sepsis. It's not the way it works. So if our goal is to make people better, this was not contributing to better. And then you could take aggregate individual data and tell the individual stories. And this was the moment where the organization got serious about bloodstream infections. This is actually from Penn. 22-year-old woman, a mother of a 2-year-old child, had relapsing acute leukemia. Penn prided itself on being the best place to get care if you had acute leukemia. Following reinduction with a very toxic chemotherapy regimen, she was found to be in complete remission. 18 days later, she developed fever and chills and hypotension. Her blood cultures drew Staph aureus. In retrospect, one of the unused lumens from her triple lumen catheter had cracked. And instead of taking the catheter out, it got repaired, a common practice. In fact, we had been fixing cracked catheters the whole time, and we're in fact reporting that about 27% of the time they got an infection afterward. What the root cause analysis in real time revealed that there was no specified understanding about when the lumens of the catheter should be flushed. And no one really understood how the catheter worked. Every time I tell this story, I remind myself to bring the catheter, because I became a student of this thing. So this is a Cook triple lumen catheter. And what you can see here is they have these blue clips, which you all recognize. And what Cook tells you is you should put the blue clip near the hub, because actually there's about 1.5 centimeters of the plastic here that is reinforced. If you put the clip here, where the plastic isn't reinforced, it cracks. And if you're only using 2 of the 5 lumens someone has, there's a high chance, if you don't understand that you're going to get a cracked lumen. In addition, our nurses at Penn, magnet nurses, had no specified understanding about how often to flush, with what to flush. You know, in the Cook instructions, it says never use larger than a 3 cc syringe to flush the catheter. Because if you use a 10 cc syringe, ever watch? Boom! It can cause the catheter to crack. Now, I consider this defective, right? At least if that's the only place that's reinforced, you have to put a color there. But we said to Cook, if you ever sell us a piece of junk like this again, we will rip your heads off. And they completely redid the catheter. But it didn't save this lady's life. 17 days after, she spent an additional 17 days in the hospital, and then died 27 days after discharge. I will never forget that. You want to mobilize a group of oncology nurses to never let anyone get a bloodstream infection. You tell the story. You tell the story. This is actionable data. What about problem solving in real time? This is observations from the same 90-bed oncology unit at Penn. This is nurses observing each other in dressing a central line. This is work we actually did with the value capture team when they were with me at Penn. So we watched magnet-level nurses on a 90-bed oncology unit, observed them dressing a catheter. Now remember, the whole world has taught us that if we just place the catheter properly, we'll be okay. But there are three parts to any catheter standard work. There's placing it, there's maintaining it, there's manipulating it. This is how we were maintaining it. Every color represents a different step, every step a different distraction, and you can see the variation. Now, when these nurses watch themselves do this, they say, you do it that way? I do it this way. But please tell me what the right way is here. How could you identify a defect? The whole thing is defective. There's no way any human being could stand there and watch a process and say, aha, that could propagate into an error, because there's no standard work. So what did we do, led by the value capture group, much like we'll do here, is we trained the 90 nurses, the 220 nurses on the 90 oncology beds to observe their own work and to improve it. We said, okay, we all agree this doesn't look good. What do you think it should look like? And this is what they came up with. 5 visual steps to dress a catheter. Nothing like we were doing. They had very innovative suggestions. Like, said, Dr. Shannon, there shouldn't be 1 mask in the kit, there should be 2, because both the patient and the nurse ought to wear one. I said, Dr. Shannon, you keep telling us the chloroprep has to dry for 30 seconds, but there's no clock in the room. Can you get us a clock? Leaders' jobs are to help workers do the work. But workers know best how to design the work. What happens when workers become empowered by 2 things? Actionable data, a 22-year-old woman that no one ever wanted to see die again, and empowered to fix it themselves. So you can see we had about 10 to 15 infections a month on the oncology unit. They started the dressing change protocol. You can see it falls to the 1, 2, 3 range. Over 1,000 days, we went from 361 infections to 12. Not 0, but a lot closer. And you can figure out what are going on in 12 infections a lot quicker than you can in 361. Sorry. So it's doing the right thing, but what I just demonstrated for you, an economically good thing. So we did the economic analysis together with some of our business colleagues at Penn and with the help of value capture, and we found out that we were spending about $11,000 more on the care of oncology patients when they got a bloodstream infection than if they didn't. That meant when we reduced those bloodstream infections, we actually saved about $3.8 million. We reduced the length of stay by nearly 11 days, which meant we admitted 623 more oncology patients to the same 90 beds over a 3-year period. No more nurses, no more staff, just open beds because we weren't infecting people. That generated $3.6 million in hospital money. This isn't the chemo, this is just the hospital. IBC, the third-party payer in Philadelphia, paid us $3.2 million in a pay-for-performance bonus. Now, a footnote there. If IBC paid us $3.2 million, how much did they make on the deal? Right? This is the economic opportunity. That money that IBC has could reduce worker premiums. This is the opportunity. So at the end of the day, we improved the operating performance on 90 oncology beds over 3 years by $11 million. And remind me, who wants to get one? Doing the right thing is the economically good thing. And 65 fewer cancer patients died as a result. In another ICU, 26-bed ICU, we reduced 3 types of hospital-acquired infections. We got another $3.1 million pay for performance. That meant in the Department of Medicine, the medical intensive care unit improved its operating performance by $5.6 million over a 2-year period. We invested $85,000 to do the work. Even I can figure out that rate of return. It's pretty good. We admitted 388 more people to the same ICU beds, and we saved 57 lives. This made safety the 3rd most profitable product in the Department of Medicine, behind oncology and cardiology. Cardiology, oncology, safety. And what if you did this everywhere? So this is data from the Commonwealth of Pennsylvania, the Pennsylvania Healthcare Cost Containment Council. 2 million people admitted to Pennsylvania hospitals. There are 163 acute care hospitals in Pennsylvania. 2 million people in the year 2011. 23,287, I'm sorry about the numbers. 23,287 people got an infection, and here's the type of infection they got. Now, if you came to a Pennsylvania hospital and you got an infection, you had a mortality of 9.4%. That's compared to 1.8% if you didn't. You stayed for 22 days as opposed to 5. You got readmitted 41% of the time over a 30-day period compared to 16% of the time. Said differently, why are we spending all our time working on readmission protocols? Why don't we just prevent infections? Think about the readmissions, we could say. And here's the kicker. Medicare payments for the care was $20,000 with an infection and $6,600 without. That's a $13,000 difference. And if you multiply that times 23,287 infections, it amounts to $325 million of opportunity in the Commonwealth of Pennsylvania. So if you're not impressed by 11 million in an oncology unit or 6 million in an ICU, there's a $325 million opportunity across the Commonwealth of Pennsylvania. What is it in the Commonwealth of Virginia? Would we really be having an argument about expanding Medicaid if we could capture this? What's our obligation to join with government in fixing that problem? Next, solving for the right problem. This is my favorite high-performance lesson. Everyone is vigilant, but we often don't solve for the right problem. And I'm going to give you another naval analogy to illustrate this. So this is a transcript from an actual radio conversation between a U.S. naval ship and Canadian authorities off the coast of Newfoundland in October of 1995. This was released by the Office of Naval Operations. So the Canadians, please divert your course 15 degrees to the south to avoid a collision. The U.S. naval ship, recommend you divert your course 15 degrees to the north to avoid a collision. Canadians, negative. We insist that you divert your course 15 degrees to the south to avoid a collision. This is the captain of a U.S. Navy ship. I say again, divert your course. No, I say again, you divert your course. Here's the collision about to happen. Escalation, right? Our favorite thing in problem solving. This is the aircraft carrier USS Lincoln, the second largest ship in the United States Atlantic Fleet. We are accompanied by 3 destroyers, 3 cruisers, numerous support vessels. I demand you change your course 15 degrees north. I say again, that's 15 degrees north, or countermeasures will be taken to ensure the safety of this ship. There you are. The Canadians, this is a lighthouse, it's your call. Now, we do this all the time, right? Shoot and then aim. So let me give you an illustration of a prime example of where we focus on the wrong thing. And it's part of every academic medical center's lexicon. And that is our reporting of death. Now, I would submit to you, death is the most elementary measure in quality. At the end of the day, our goal, where we can, are to prevent people from dying. Now, there are some circumstances, particularly in places like this, where people come here with very advanced illnesses and they're going to die. But I would argue, even there, do they have to die in an academic medical center? Aren't there better places for people to die? But for the moment, most of us report this data through the UHC mortality database. Now, I think all of you know that the UHC data is based upon administrative billing data. That's the way the UHC calculates this. Now, it doesn't say dead in the bill, but it does tell you the complications that allow the UHC to create this very complex number called the expected mortality. And the expected mortality is there to make sure that nobody, tries to claim that they don't have people dying that are equally sick, right? It's one of these denominator phenomena, very complex. They change it every 2 years just to keep you in the game and make you pay more. And they take billing data to basically do this. I have no idea what we pay for this, but it isn't worth $1. It isn't worth $1. Let me tell you why. The consequence of this, and this is at least when I was at Penn, I can't say this is true here, as we hired an army of coders to take the record and make sure before it got to UHC that every possible fingernail violation in that human being was coded. This will become very interesting with ICD-10. I don't know if any of you have looked at this, like 760,000 codes. Now, if you break your arm, it's not you broke your arm, it's you broke your arm in the left wrist or the lower part on the 3rd day of the month, and you did it knitting. That's how it gets coded. I kid you not, right? This is ICD-10. So we had an army of people down there coding it to make sure we picked up every comorbidity so that our expected mortality would be high. So we didn't have to worry about the fact that people were dying because our ratio would be better. So when we were there, we said, well, that makes no sense at all. The problem is death, not coding. I never saw coding bring someone back to life. I don't understand this. So, and why does it take 6 months to get the data back? Because it takes that long to code it. And then UHC to massage it. What if actually we reviewed every death? Every death. That a tribute to the person that died was we stopped and honored them, as they do in our emergency room when people die with a compassionate moment. But we honored them as healthcare professionals by saying, what happened here? Simply, was the death expected or unexpected? A simple question. So we looked at deaths at HUP in 2012, where the Hospital University of Pennsylvania ranked 26th in UHC mortality. Now I can assure you, nobody at Penn thinks they're 26th at anything, even if they are, right? So this was all kinds of controversy. There were 804 deaths at the Hospital University of Pennsylvania. 462 of them were in my department. And up until this point, I never spent a moment thinking about it. So it turns out when you looked at the data, 49 of the deaths were in people admitted electively to the hospital. What's that all about? And actually 89 deaths occurred in people that had a relatively low case mix index. What's that all about? And 59% of the deaths at HUP had one or more hospital complications. Interesting. Opportunity to do something. So we simply asked a series of questions, and Larry Gimple has started this in cardiology here. I want to really acknowledge and give him credit. Simple question. Every morning, on my desk appeared one list. Who died last night, whether it was expected or unexpected. If it was unexpected, what happened? And then a clinical vignette, 3 sentences. Who the person was, where they lived, what their condition was, and why they died. And then we moved on to look at what we call bumps in the night. People that didn't die on the floor, but got transferred to the MICU, which was sort of an early, the canary in the cave that something was going on. What we found was that 20% of deaths in the Department of Medicine were unexpected. Somebody on the team, a medical student, a nurse, a respiratory therapist, said, boy, when I went home last night, I didn't think the guy was going to be dead. And that was all it took. Anybody could say, didn't think the guy was going to die. And we looked into it. And we found 2 really important things. First of all, a quarter of all the unexpected deaths were in people that aspirated. Older people, confused people, people back from procedures, not yet awake from their sedation, forced to eat dinner, people with diabetes who have difficulty swallowing. Easily recognizable risk factors. And then secondly, we found there was this problem with the delay in appreciating who was sick. That was particularly true of heart failure patients and liver failure patients. That those people lived precariously with one foot on a banana peel and the other over the edge. And that you needed to recognize that when you left that day. That anybody with heart failure, anybody with liver failure was someone trying to die. So we raised our level of awareness around those things. This is what Jeff Young refers to as picking up weak signals before they propagate into a disaster. So what happened? We initiated a program called SIT-UP, which was an algorithm to identify and prophylax individuals who were at risk for aspiration. And we put an all-points bulletin out on every heart failure and liver failure patient in the hospital, such that at the time of sign-out, there was literally an all-points bulletin as to what the metrics were at that moment and what the anticipated course was over the next 6 hours. So what happened? You can see on the bottom here, for the previous 4 years, we had basically the same number of deaths in the Department of Medicine we had always had. Yet, our UHC mortality ratio was going down. And everybody's high-fiving each other over this. But if you're the family of one of these people, I'm not quite sure you're so excited about our UHC mortality data. Then we said, what if we actually do away with unexpected deaths? And you can see between 2012 and 2013, there were 81 fewer people that died by just doing the 3 things I described to you. Not watching the data, but intervening on the data. And you can see that suddenly when you actually prevent 81 deaths, you have an exponential decline in your UHC mortality, such that you render the denominator meaningless. The best way to have high performance in UHC mortality data is to have 0 deaths, not to code them properly. Focusing on the right problem. Then the final thing I want to mention, I'm just on time, really important, and something I have never mastered but would love to do here, and that is engaging the wisdom and the skill of every worker in the pursuit of safety and quality. And I'm going to give you just a brief anecdote. When we first started doing this work at Allegheny General Hospital in Pittsburgh, every time there was a suspected event, in this case a ventilator-associated pneumonia, we convened a team within 24 hours at the bedside to figure out what happened. Not who done it, but what happened. So even a suspected ventilator-associated pneumonia got looked into because there was an idea that we might learn something. Myself, the nurse manager, the nurse taking care of the patient, the social worker, the resident, the medical student, and eventually over time, the environmental services person. And we did things that everybody else did. These are sort of the bundles around preventing ventilator-associated pneumonia. They're all familiar with them. We customize this, right? I think a really important thing is take what others have learned, but customize it. When you develop it, you own it. When someone else develops it, they own it. Customization of standardized protocols is important. There were a couple of things we did, like we said, you got to check the endotracheal tube. That wasn't part of the NHI bundle. We said, the reason people aspirate is because the tube leaks. We ought to check the endotracheal tube. And we just made standard work around checking the endotracheal tube. We actually started out by checking it every 6 hours. And we realized you don't need to check every 6 hours, check every 12 hours. But you test it to try and see how you're doing. And who did it? The respiratory therapist, right? Who, what, when, where, how, and why. But this is the one I want to call your attention to. Provide a hook for hanging the ambu bag, this resuscitation bag, it's the ambu bag. So this is the story of what I call Chev versus Hook. So one day we're doing one of these root cause analysis, and the environmental services guy, his name was Chevra, is in the room. And we're talking about what happened. The guy raises his hand. He says, Dr. Shannon, I'd like to share something with you. I said, by all means, Chevra. He goes, I clean this room every day. Every day I take care of this room and the 4 next to it. And I come in and I see this blue bag. I don't know what you call it. So that's the ambu bag. I see that blue bag everywhere. One day it was on top of the ventilator. I said, well, maybe that's okay. So one day I found it in bed with the patient, like a teddy bear. He said, and I knew something was wrong the day I found the ambu bag on the floor next to the urinal. And he said, I don't know very much, Dr. Shannon, but I'm pretty sure it doesn't belong there. So if I were you, and I could hear him say, if I were you, big guy, I would go to Home Depot and I would buy a bunch of hooks and I'd put them in the wall and I'd put a little sign next to it that says, the blue bag goes here. And we did it in the 26 rooms. I think it cost $1 to do this, right? Why did we do it? Not because I could ever prove to you that happened, but when you've got the environmental services person contributing to safety, you have all hands on deck. You have a system-level, Normandy Beach-like approach to safety. That's the key. That's when we'll know we're there. All right. So what are we doing? We've Said we're going to be the safest place to receive care. We're going to be the healthiest workplace. We're going to provide the highest level of care as measured by expertise, service, and outcome. Our biomedical research will be focused on the betterment of human condition that will train the healthcare workers of the future in interprofessional teams. It begins with a couple of preconditions. Namely, if we don't do the following, we can never achieve those goals. Those preconditions are everything we do when we come to work must be focused relentlessly on what patient wants and needs. The personal agenda has to be checked. Our work must be about that. And we have to create this physically, emotionally, and professional safe environment as defined by what I call the Paul O'Neill trilogy. Every day, every worker can say yes to the following three questions. I am treated with dignity and respect regardless of my rank in the organization. I'm given the tools that allow me to make a contribution that adds meaning to my life. See Chevrer's hook. And I'm recognized for what I do. Gallup engagement surveys are important. They're episodic, but every day, every worker in this organization should be able to say yes to those three things. And when they do, we will have full engagement. We are making great progress thanks to the hard work of many people in this organization. So between 2011 and 2013, we've had 38 fewer hospital deaths at UVA. We've had 57 fewer pressure ulcers, 71 fewer catheter-related UTIs, and 40 fewer bloodstream infections. Sizable improvement over a 2-year period through hard work. But now we must change faster. It would only be fitting to end a rounds like this with a TJ quote. I hold it that a little rebellion now and then is a good thing, and is as necessary in the political world as storm is in the physical. It's time for a little rebellion. It's time for a little overthrow of harm. Change is the new norm. We must accelerate our pace of improvement. What we do will not change, how we do it must. And I ask you, please, don't be a bystander. Join Chevrer's charge to say everyone has something to offer. Now, I love Thomas Jefferson, but I'm a real fan of Theodore Roosevelt. This is my favorite quote, and this is the inspirational game on quote. This is Roosevelt who said, "It's not the critic who counts, not the man who points out how the strong person stumbles or where the doer of deeds could have done better. The credit belongs to the person who's actually in the arena, whose face is marred by dust and sweat and blood, who strives valiantly, who errs, who comes up short again and again, because there is no effort without error and shortcoming, but who does actually strive to do the deeds, and who knows the great enthusiasms and great devotions, and who spends themselves in a worthy cause, who at best knows in the end the triumph of great achievement, or at worst, if they fail, they at least fail while daring greatly, so that their place will never be with those cold and timid souls who know neither victory or defeat." Game on. Thanks a lot.
So much, and we have a few minutes for questions, and you heard him, don't be a bystander. So those of you with questions and comments, we have a few minutes to take those, and there's this mic and another one in the audience so everyone can hear you and can go on the tape as well. Don't be a bystander. And please tell us who you are.
Thank you for that. That was wonderful and inspiring, and we all need that. I am Lynn Nolan. I work for several groups, School of Nursing, the Division of Nephrology, and the VP for Research. So my question to you is, what do you look at every day on your desk first thing?
So this is still evolving, but the things I will, and Tracy and I are working on this as we speak. So there are 4 things that I'm pointing toward now, and that is deaths. I'd like to know who died last night. I'd like to know about any bloodstream infection or any catheter-related urinary tract infection. Right now, I get a report on that weekly. I'd like to see it daily. The work of improvement has to be every day. And then the fourth thing is a measure of worker safety. So how safe is the organization? We're going to begin by me seeing every day who got hurt yesterday, as evidenced by a report to employee health. Who got hurt? And then using that to figure out how did they get hurt. And by investigating how they got hurt, trying to eliminate the root cause of that so that nobody gets hurt at work at UVA.